current advisor to the president. And Dr. Gautam Samadar is a board certified pulmonologist and sleep medicine. He also a past president. Indeed, both are very esteemed members of the organization. I let Dr. Gautam Samadar start the program, today's section of webinar on pulmonary. Thank you very much, Gautam.
Thank you, Sudhakar. Vijay, I'm on?
Yeah.
You are.
Thank you. Thank you, Sudhakar. It is my honor to introduce the speakers for today's program. There are some ground rules. Each speaker will get about 15 minutes, and all the three speakers will speak one after another. And after that, if there is time left, we will have some question and answer session. So with that in background, I wanted to introduce the first speaker, Dr. Gopal. He's an infectious disease expert and has been practicing medicine for the last 25 years. He was trained in Duke University and University of Tennessee. He's a medical director of infectious disease program in Broward Health North, practicing South Florida community. And she's well recognized both in Florida and other parts of the country. So with that, let me introduce Dr. Gopal for this session.
Hello. Thank you for the introduction. Can you hear me?
Yes.
Yes.
It's my pleasure and privilege and honor to be here talking to you all. I'm an infectious disease specialist. South Florida is my home. I go to 4 major hospitals in this area, and I have my private clinic also. I have seen more than 1,000 COVID-19 cases since March. As you know, COVID-19, it varies from patient to patient, and we cannot make broad generalizations like we do for other diseases. Treatment is customized to a certain extent, and the decision making has been on a case-by-case basis. I will be talking about remdesivir, corticosteroids, tocilizumab, and convalescent plasma. So next slide. Can you see the slide? Next slide, please. Next slide. Okay, I'm going to talk first about remdesivir. It is a broad spectrum antiviral agent. It has antiviral activity against Ebola virus, MERS-CoV, SARS-CoV-1, Nipah virus. The mechanism of action of remdesivir is it latches on to viral RNA chains, resulting in premature termination of those chains. The remdesivir formulation contains cyclodextrin, and that accumulates in kidney failure patients. So if a patient is a dialysis patient, or if the creatinine clearance is less than 30 ml per minute, remdesivir is contraindicated. If the AST level is greater than 5 times normal, we cannot use remdesivir. If somebody is taking Plaquenil, it may diminish the therapeutic effects of remdesivir. So we will have to stop the Plaquenil while we are giving remdesivir. As you can see on the slide, this is a randomized controlled trial. The name of the trial was Adaptive COVID-19 Treatment Trial, that is ACTT trial. It was done by National Institute of Allergy and Infectious Diseases. They announced their interim result on that randomized controlled trial. Next slide, please. What they did was they had about, next slide, yeah. They had about 1,000, close to 1,000 patients in that study. Half of them got remdesivir for 10 days, and the other half got placebo. So what they found was the median time to recovery was 11 days for patients treated with remdesivir versus 15 days in the placebo group. So there was a 31% faster time to recovery than placebo. The survival benefit was not statistically significant in that study. Gilead did another study that is a simple trial. It was simple. They had 400 patients, 200 patients got remdesivir for 5 days, and close to 197 patients got remdesivir for 10 days. So they looked at the 14-day clinical improvement. So by 14-day, what they found was the 5-day course actually did better. It was like 64% versus the 10-day course group had 54% benefit. There were some limitations to that study. They didn't have a placebo group. The 10-day group had more sick patients. And because of some of the people in the 10-day group got discharged early because they got better. Because of the pandemic situation, the patients were not kept for 10 days. So you have to take that study with a grain of salt. 2 days ago, they announced another study that also showed that the 10-day course of remdesivir is not beneficial. The FDA, May of this year, FDA gave an emergency use authorization for remdesivir for patients with severe COVID-19. They defined it as having an oxygen saturation in room air less than 94%, or mechanical ventilated patients or ECMO patients. 2 days ago, the FDA has expanded the indication for remdesivir. What they have said right now is any patient with COVID-19, we can give remdesivir. Next slide, please. I'm going to talk about the corticosteroids. I'm sure most of you have read through this study. This is the recovery trial. It was an open label trial. What they did was they randomly assigned about 2,104 patients to either dexamethasone 6 milligram oral or IV dexamethasone for about 10 days. And then about 4,331 patients, they got the usual care. The conclusion of the study was in hospitalized patients with COVID-19, the use of dexamethasone resulted in a lower 28-day mortality among patients who were receiving either mechanical ventilation or oxygen alone. So this is pretty straightforward. We all know about the steroids. So I'm going to move forward. Next slide, please. This was the details of the recovery study. Next slide. Next, I'm going to talk about tocilizumab. Previous slide, yeah, perfect. So the tocilizumab, before I talk about tocilizumab, the other name of it is Actemra. I want to refresh your memory about the pathogenesis of COVID-19. So the spike protein will bind to ACE2 receptors in the alveolar epithelial lining of the lungs. The SARS-CoV-2 has tropism to other sites, pharyngeal, GI, myocardial, brain, and renal. So that's why we see all these extrapulmonary manifestations. Immediately when it attaches to ACE2, it causes a direct cytotoxic effect to ACE2. And then it causes a dysregulation of renin-angiotensin system. There is endothelial damage, thrombus formation, and there is a unique pathogenesis mechanism seen in severe COVID-19 patients. What it causes is hyperactive innate immunity. So our own immune response becomes hyperactive against us, and it causes massive amounts of cytokines. One of the substances is interleukin-6. So that's where this tocilizumab, the drug comes into play. So people who have, cytokine storm syndrome, tocilizumab is an option. That what it is a recombinant humanized monoclonal antibody that will act against the interleukin-6 receptors, either soluble or membrane-bound form. But there is one major caveat to this drug. When we give this drug, we are actually weakening the patient's immune system. So it will cause serious infections. tuberculosis. If somebody has latent TB, TB can reactivate. And then invasive fungal infections, candidiasis, aspergillosis can happen, secondary bacterial infections, and also pneumocystis has been, it all is possible. One unique side effect of this tocilizumab is diverticular perforation. So as a clinician, we have to be aware of that. If the patient is vented, sedated, if there is increase in white count, we have to be thinking about it. If they got the Actemra, we have to be thinking about it. So talking about the studies, we have mixed information about tocilizumab. This was a study where they had a sample size of about total of 154 patients. 78 patients got tocilizumab. That is a pretty okay sample size for this medication. So what they found was the tocilizumab treated patients had lower mortality. So there is another retrospective study that was an Italian study that was published in Lancet, August of this year. That was for severe COVID pneumonia patients. That is called TESIO study. The sample size was 179 patients. That is pretty good, sample size for this drug. The 88 of the patients got IV tocilizumab and 91 got subcutaneous tocilizumab. What they found was this medication prevented the patients from getting into mechanical ventilation, and there was a reduced risk for mechanical ventilation and death. One thing that was found, one thing that I noticed were the patients who got tocilizumab had 13% secondary infections versus the standard of care patient had only 4% infections. Talking about monoclonal antibodies, currently NIH is doing another trial that is ACTIV-2 trial, that is Accelerated COVID-19 Therapeutic Interventions and Vaccines. It is a public private partnerships. It is sponsored by Operation Warp Speed. They are testing a monoclonal antibody. What it is they will take an antibody from a patient who has recovered from COVID-19, and they will make copies and synthesize it in the lab. It is very pure, it's highly specific, and currently the trials, phase 2 is going on. There is the first one, the name is called LI-COVID-555. It is a collaboration between Eli Lilly and Abzellar Biologics. And the phase 2 is going on in UNC and California. So I'm looking forward to it. It may be highly promising for cure as well as prevention because this is very pure. Next slide, please. So the next is about convalescent plasma. So the convalescent plasma, the concept is simple. If somebody is getting COVID infection, we take the plasma from them and they infuse it to a sick patient. The FDA just now gave the emergency use authorization for plasma. And then I read yesterday, they have stalled the decision because there are a lot of comments from people that there is no randomized control trial saying that this plasma is beneficial. In our facility, we have at Broward, what we did was they have enrolled in the Mayo Clinic trial. This is an open label expanded access program for convalescent plasma. It's a multi-center, about 2,800 centers in the US. I saw some preliminary report between, April and July, they had transfused about 35,000 people, and that was like life-threatening COVID cases. And what they found was they looked at the 7-day mortality, and what they found was if the plasma was given within 3 days of, they did a little bit better on mortality. And also they looked at the antibody level. If somebody got a plasma with high antibody level, they did a little bit better on mortality. The side effects of plasma, as with any blood products, allergic reactions, acute lung injury, shortness of breath, and then very rarely transmission of blood-borne pathogens, HIV, hepatitis B, Hep C, which, this is very, very low because they have to go through FDA regulations. So to conclude, when I see a patient with COVID-19, I ask myself 3 questions. Is the patient symptomatic? Number 1. Number 2, is the patient having mild, moderate, or severe disease? And number 3, does this patient have cytokine syndrome or macrophage activation syndrome? So the treatment is based on that. If I am seeing a patient asymptomatic, I do see them because sometimes before surgery, they do COVID testing. Just before going home to nursing home, the COVID testing comes back positive, no symptoms, labs are fine. I don't do any treatment for them. They do completely okay. Then the mild disease, if they are hypoxic, we have to give them steroids, dexamethasone or other form of steroids. And then I look at the risk factors and stratify them. So if there is a patient, I'm seeing them with high other risk factors like diabetes, high blood pressure, metabolic syndrome, cardiovascular disease, obesity, chronic kidney disease. These are all risk factors for them to go into severe COVID. So then I will be giving them remdesivir. And then August 28th, CID, they did a article. It was a very nice article. They had about a huge number of patients, 11,000 patients, 11,700 patients. And that was done in 245 hospitals. What they looked at the patient characteristics and outcomes. So what they found was male, older age, obesity, chronic kidney disease, and pre-existing cardiovascular disease. These were all people associated with increased odds of mechanical ventilation. So all these risk category, I'll be looking at it. And then I will evaluate them for cytokine storm syndrome. So there are certain biomarkers we can check. Those are the biomarkers, ferritin, CRP, LDH, D-dimer, AST, ALT. These we can measure. But then there are certain other biomarkers like interleukin-6, interleukin-18, neopterin, gamma interferon. All these things are sent out. And in the books and trials, and I see it can be done, but in Florida, I didn't have opportunity. I couldn't send out these interleukin-6 also, I couldn't send out. So I basically look at them in the clinical picture. And then if they're when I give dexamethasone and when I give them remdesivir, if the patient's oxygen status is worsening, if there is sudden deterioration of oxygenation, or if they have to, go into like BiPAP and, if there is worsening, there is role for Actemra. That's the one area where, and there was a case where the patient rapidly deteriorated, oxygenations was very worse, and then the ferritin, everything was very high, and we said, okay, let's transfer the patient to ICU. They didn't have ICU rooms. Patient stayed on the floor. We gave 1 dose of Actemra. The next day, the patient was actually better. It prevented the intubation, and then we said, okay, cancel the transfer. We didn't have to. So I don't know whether it was just anecdotal. So this, in our facility, the tocilizumab decision is based on 2 physicians have to agree, either an infectious disease and a pulmonologist, or an intensivist and infectious disease. So that's how we do it. That's in the Broward facility. In another facility where I go, they actually, they don't have tocilizumab. There was a trial like Covacta trial. So that trial showed no mortality benefits. So we don't get tocilizumab. In some centers, it is only on, tocilizumab is given only on a trial basis. I mean, so we need more data on that medication to come. So next slide, please. Vaccines, since I don't have much time, I would say there is hope. We have vaccines. These are the phase 3 vaccines: Moderna vaccine, Pfizer BioNTech vaccine, the Oxford's University vaccine, that is a Chadoxi vaccine, China's CanSino adenovirus vaccine, and then Sinovac vaccine. These are all the ones in phase 3 right now. Novavax that's a nanoparticle technology that's not in phase 3, but I just put it there. Worldwide, there are 2 vaccines that is approved with limited use. One is, I'm sure you all know about Gamaleya Institute, Sputnik vaccine in Russia. They didn't do phase 3 trials. And then there is a China in military, only they approved a vaccine. Again, they didn't do phase 3 on that. And there, all over the world, there are some other things going on like BCG. There is some repurposing. There is a study going on in Australia and everything. So there is definitely hope, and we will be able to, we'll be able to come out of this in a very good way. Thank you.
Thank you, Dr. Rao. Vijaya, can you hear me?
Yeah, we can hear.
That was excellent presentation, and we'll reserve the questions at the end of all the three speakers. Next speaker is Dr. Sunil Kumar. He is a proud member of API. He was a past president of AKMG. He is the medical director and ICU chief in Howard Health Medical Center, well-trained, fellowship trained in pulmonary and critical care. So we're very fortunate to hear from him. And he will be focusing more on the ICU setting, how his experience with COVID positive patient in ICU setting. So Dr. Sunil Kumar, welcome.
Thank you, Gautam. Good evening, everyone. Can you all hear me?
Yes.
Okay. First of all, thank you, Sudhagar and Api, for inviting me to this talk today. And I don't know the type of doctors participating. So for some, this could be too much information, but others like Gautam, Dr. Reddy, and Dr. Sudhagar, this could be too little. So my apologies ahead of time. Next slide, please. Next. I have absolutely no conflict of interest. Next. So as we all know, COVID has multiple phases. The most common phase that we see is the slow plateau phase, but unfortunately there's a rapid, unpredictable transition. So because of that, it makes it extremely difficult for us to assess who's going to get worse and who's going to do very well. So in inpatient pulmonary, we divide these patients into 4 different stages. So I will go through those stages and I'll describe why those stages are important. Next, please. So first is a asymptomatic or silent hypoxemic phase we sometimes call the happy hypoxemia patient. They're really not very symptomatic. They need some low flow oxygen. Sometimes they have shortness of breath. Sometimes they have cough. Mostly they're asymptomatic. But then you have this next phase where the respiratory insufficiency starts, where the requirement for oxygen goes up. They require like 10 to 15 liters of oxygen. The secretions are worse, much more difficult to cough, and they start having air hunger. And anxiety also plays a role here. In my opinion, from all the experience that we had so far, I think this is a stage that we really want to pay attention. This is a warning stage. There are a lot of warning signs there, because the next 3 stages, stage 3 and stage 4, are much more difficult to handle because so the cytokine storm has already started. So in respiratory phase, that's a typical ICU patient that we see. They have severe, moderate to severe VQ mismatch. They have fevers and rapidly rising CRP and all those things. But some interesting thing that we have noticed, and I'm sure you all have noticed, is there's not much of vasodilatory shock or cardiogenic shock. These patients are hemodynamically stable when they initially come. Not all of them. Some of them have cardiac dysfunction as well. And of course, the stage 4 is a rapid death or the steady resolution phase where we can mostly pray and hope that things will get better. The patients with multi-system organ failure, they don't survive. And that's where the maximum cytokine storm is. And some of these patients drag on and they get better. Some of them survive and do very well. So what can we do to prevent the progression? Of course, medications are there. We're trying all different medications. Like Dr. Gopal said, not too many randomized controlled trials are there. So we're trying and testing everything. But there are other things that we can do. There are non-pharmacologic techniques there, non-invasive, and then of course, we get to the invasive phase. So let's look at that one by one. Next slide, please. So refractory hypoxemia in severe COVID is classic, right? Once they are sick enough, they have severe hypoxemia. There are so many different theories why they are hypoxemic. So we see typical ARDS and atypical ARDS. We clearly know there is a thromboembolic process. There is a vascular component. Pulmonary hypertension is there in some patients. Then there is pneumonia. Pneumonia itself is controversial. There are studies that showing that these are probably not typical pneumonia. Maybe these are vascular ischemic changes that we are seeing in the chest X-ray. Autopsy studies showed, fibrinous and organizing pneumonia, which is classic. But one thing that we are seeing more and more in autopsy studies, there's some kind of diffuse endothelial injury that these patients have, which is very fascinating. And of course, pulmonary embolism, some patients also come into myocardial infarction and pulmonary edema. So these are all the causes for refractory hypoxemia in these patients. Next slide, please. So one more point before we get to that, autopsy studies also showed bronchopulmonary anastomosis. Just a brief anatomy of that. If you all remember, pulmonary artery breaks up into capillaries and forms a pulmonary vein, goes into the left heart. And we do have some bronchopulmonary anastomosis in the lung, not physiologically significant. But what they are also seeing in COVID patients, these bronchopulmonary anastomosis are very significant. So there are multiple right to left shunting happening, and that also is probably contributing to the severe hypoxemia. So talking about proning, if you all remember, when you are lying flat, when you're supine, your transpulmonary pressure is higher in the anterior part, and the transpulmonary pressure is low in the posterior aspect. So there is alveolar dilatation anteriorly and alveolar constriction posteriorly. And the dependent lung gets a lot more blood flow than the non-dependent lung. So there is a significant VQ mismatch anteriorly as well as posteriorly. So if you're able to disrupt that, we can improve oxygenation. That's the theory behind proning. So it's not standard practice to do proning outside of ICU, but as physicians, clinicians, we all have figured out that there is a benefit in doing proning in these patients even without intubation. So in our hospital, we've been proning pretty much all patients, even on the floors. They self-prone. We give them instructions to do those. And if you do it early, there's clearly a benefit. Next slide, please. So this is a study that was published in Academic Emergency Medicine. So Nicholas Caputo and associates, what they did was, in the emergency room, they took about 50 patients. When their SATs were less than 85%, they proned them. And what they found was, within about 5 minutes, all their SATs went up over 94%. And in their study, they showed only 13% of those patients eventually got intubated. The rest of them survived. So there was a mortality benefit as well. Next slide, please. So similarly in JAMA, Allison Thompson and associates, they published a paper. They also did non-intubated patients proning. And what they did was they took about 88 patients. When the respiratory rate was more than 30 and O2 saturation less than 93%, they did proning on these patients, and only 37% of patients required intubation. So overall, from these two studies, it shows that even non-intubated patients do have benefit by proning. Next slide, please. So it decreases intubation rate, it decreases the atelectatic changes, and some of these patients, when they come in, they are sick enough, and the family or the patient makes themselves DNR, and probably a beneficial thing on these patients as well. Next, please. So we definitely saw some improvement, and several small observation studies have confirmed these findings. Definitely not a miracle cure like you see in the media, clearly not. I mean, the survival benefit is still unclear, and we clearly need randomized controlled trials to prove this, and there are many studies underway in the United States. Next, please. So when do you prone? Recommendation is to prone these patients about 6 to 12 hours post-intubation if they're intubated patients. You can do it sooner. We actually, in our ICU, once we intubate the patient, if they get intubated outside of ICU, as soon as they come, if they're hemodynamically stable, from the stretcher to the bed, we prone these patients, and we have seen significant benefit. Obviously, you look at the PF ratio, and proning was mostly on patients with PF ratio less than 150. Next, please. This part is very important, something to consider when you're proning these patients. It's not easy to prone these patients, very difficult to protect their airways, and those proning beds are not freely available in all the hospitals, and not many beds are available. So obviously we are manually proning these patients. So these patients need to be sedated and paralyzed, make sure their RAS score is at least -4 to -5. Pyloric feeding is okay. We have been feeding all these patients when they started proning and they're stable. We did ABG supine and prone to see the difference and see the benefit. And we have many patients who are on vasoactive drugs, and it's not really a contraindication. The last part is extremely important, a prone team. It really helps, and it makes the whole process much more coordinated. And we had a particular time every day that we proned all the patients. So the proning and supine were done exactly at the same time. It also helps to plan procedures and plan dialysis and all those things. Next slide, please. So when do you stop proning? When you have all these complications. If you see barotrauma, hemodynamic instability, and you see there is no benefit in proning these patients after you see there's no improvement in oxygenation, you can stop. Like I said in the beginning, earlier, dialysis is challenging, but you can adjust the timing and you do dialysis on these patients. So definitely once the PF ratio is over 200, at least you have stability for at least 24 to 48 hours, then you can stop the proning process. Next slide, please. Let's talk the next controversial thing most of us did, is anticoagulation. It's an uncharted territory, but we all know incidence of VTE in COVID is not well established, but there are studies showing anywhere from 1% in non-ICU patients to all the way up to 69% in ICU patients. So that's a significant number. Next, please. So how do we decide how much anticoagulation, what do we give, and all those things? So there are different theories. So this is one paper in Journal of Thrombosis and Hemostasis. That's from Tang and Associates. What they did was they measured D-dimer and looked at outcomes, and they saw worse outcome with D-dimers, high D-dimers equal to worse outcomes. Next slide, please. So another study from Tang and Associates in the same journal, what they did was they took about 449 patients and they gave them DVT prophylaxis. And what they found was 28-day mortality was decreased by about 20% in patients when the D-dimer was over 3,000. So many centers use D-dimer as a guidance for anticoagulation. So what we did, like several other centers, when the D-dimer is over 6 times the upper limit of normal, we gave them full dose anticoagulation. When it was 3 to 6, we use half the dose of anticoagulation. And if it is less than 3, we just kept them on prophylactic anticoagulation. We also use TEG in some of these patients, but as you all know, TEG only tells you the hypercoagulable state. There is not enough data to support how you direct that anticoagulation process in these acute patients. Next slide, please. So all adult patients should get pharmacologic thromboprophylaxis if they can tolerate it. Low molecular weight heparin, probably better to reduce the contact. And if you have a hit, you have alternative drugs available. And if anticoagulation is contraindicated, of course, they definitely should be on mechanical thromboprophylaxis after you rule out DVT. Next slide, please. So let's talk about, so those were things routinely done. And then we get into a controversial topics of non-invasive ventilation, that is CPAP and BiPAP, and high flow nasal canal O2. So I'll go through that. So if you all remember the early reports from China and Italy, what we were told is intubate all these patients, early intubation, it's preferable. So we all started doing that. And then we all started, reassessing, ventilators are limited, and weaning off these patients from ventilators extremely difficult. And then we even started talking about maybe trach them. We actually trach some of these patients on day 7. And it had its challenges, but it was definitely beneficial. So why not use non-invasive ventilation? Next, please. So there is growing evidence that non-invasive ventilation, CPAP or BiPAP, is beneficial, especially if you use it early in the process. So you can prevent deterioration and even prevent invasive ventilation. It does improve oxygenation, and by supporting increased mini ventilation requirements. As you all remember, these patients are have significantly elevated minute ventilation. They're air hungry, and some of these patients can be protected or helped with non-invasive ventilation. Next, please. Then came high flow nasal cannula. This is one of my favorites, even though there's a lot of controversy around using high flow nasal cannula O2, especially because aerosolization is a concern for all of us. Most of the hospitals, the ICUs and floors where these patients were, in our hospital especially, all those rooms are converted into negative suction rooms. We were all using PAPRs and N95s and all of those things. So clearly there was protection. Well, there is benefit, right? As we all know, standard oxygen is cold and dry. It increases your airway inflammation, increases airway resistance, and impairs mucociliary function. If you remember these COVID patients, they have a lot of secretions. The secretions are very thick. So there's clearly a benefit in using warm and humidified air, oxygen. Next, please. And high flow nasal cannula O2 isn't new for COVID. If you all remember the famous FLORALI trial that was published back in 2013 in New England Journal of Medicine, we saw that by using high flow oxygen in respiratory failure, you can actually decrease the number of intubations. So it decreases a pharyngeal dead space, obviously washes out CO2 and replaces with oxygen, and prevents intubation and further respiratory failure. In COVID patients, there were 2 papers published. One in American Journal of Respiratory and Critical Care Medicine in August by Demoli and Associates. They clearly showed by using high flow nasal cannula O2, you can actually decrease the mortality in COVID. And also improved oxygenation and decreased minute ventilation and workup breathing was also clearly documented in another paper by Maury and Associates, both in the American Journal of Respiratory Critical Care Medicine as well as Intensive Care Medicine. Next slide, please. So again, you can go to the next slide, please. So, high flow oxygen, you can deliver up to 50 to 60 liters. Theoretically, every 10 liter produces a millimeter mercury of PEEP. So theoretically, you can get up to 6 millimeters of mercury of PEEP by using 60 liters of high flow. So by doing that, it increases FRC as well as increases alveolar recruitment. In CHF patients, it's beneficial because it also decreases your preload. Next, please. Mechanical ventilation. I won't go too much into details on mechanical ventilation. Obviously, we're all familiar with these patients when their minute ventilation is 25, 30 liters. You can't survive with non-invasive ventilation or high flow oxygen. So these patients need to be intubated. They also become significantly acidotic from a metabolic process. You get a lot of muscle fatigue and everything. So they develop acidosis. They develop augmentation. So obviously all bets are off. You got to intubate them and put them on mechanical ventilation. Next, please. So the key in once you intubate them, the key is the sooner you sedate them well, and even using paralysis, you can give bolus paralysis because you want to control the respiratory dyssynchrony that you have. And not only that, it makes it much more easier for you to use pulmonary vasodilators. Nitric oxide, inhaled nitric oxide is one of my favorites. We have seen significant improvement in patients' oxygenation by using nitric oxide. Now, all patients don't respond to that. If you don't see any response in about 6 to 8 hours, you can always wean them off the nitric oxide. Otherwise, you can continue, and it does help. And currently, studies are being done where they're studying nitric oxide for its antiviral properties. So more to come on nitric oxide. Once you intubate, you also want to keep a good peak inspiratory pressure and plateau pressure. You want to decrease barotrauma because we have seen a lot of, not quite a bit of pneumothorax, but we have seen pneumomediastinoms on these patients. And, optimum PEEP is clearly something we should look into because all of you, as you all know, there's typical ARDS and atypical ARDS. There's a group of patients where the lung compliance is normal. And you don't really need very high PEEP for these patients. You're probably going to hurt them by giving them high PEEP. And then absolutely actively wean these patients And we have had success extubating these patients to either high flow or BiPAP from ventilator and not needing to re-intubate these patients. So that is something to consider. Then comes ECMO. So ECMO is not new to the pulmonary critical care world. I mean, the landmark trial, the CESAR trial that was published in 2009, clearly showed that there is benefit in a group of ARDS patients if we use it wisely and use it early. And this study originally came from United Kingdom, and they showed benefit. And we all know from the H1N1 subgroup, there was about a 73% benefit. Next, please. But the decisions in ECMO should be made early. You have to clearly look at the Murray score and the RESP score and make a determination on who clearly is going to benefit from this. Next, please. Next. So these are two studies, one published in American Journal of Respiratory and Critical Care Medicine. Next, please. Reduce mortality in high volume centers. So this is the key. You don't want to start ECMO in a center where you have only done 2 ECMOs in the whole year. There is enough data to support even the CESAR trial. They actually transported all these patients to high volume centers, and that's how they were able to show that mortality benefit. Next, please. Next. The data is still pretty bad. If you look at data from the Chinese studies, the mortality wasn't good. Even some of the early data that came from United States data is pretty grim. So we still need a lot of more information before we jump into ECMO. And you also have to remember in the middle of a pandemic, we have to be careful. These patients, when they are on ECMO, they last for 5 to 6 to 10 weeks. But clearly, if you have a single organ failure and the patients don't have multi-organ failure, there is clearly a benefit in using ECMO for these patients. Next, please. We spoke a lot about pulmonary. In the beginning, I was talking about endovascular injuries. So if you look at all the other injuries that we saw in ICU and before ICU, there are a lot of young patients coming with stroke, young patients coming with myocarditis and coronary artery disease. There are AKIs, unclear etiology. So all these could end up being a vascular disease in COVID. Well, that's a bold statement. We don't have answers for it, but more to come on that. Next, please. ICU mortality is still high. It goes anywhere from 30% to some centers up to 50% mortality. Next, please. Well, it's one thing to remember. Again, like prone position, it's a team that makes a difference. One person cannot make a difference. So I want to thank all the frontline workers for an amazing job that we did in this country. And thank you again, Api, for inviting me. Thank you.
Thank you, Dr. Kumar. It was excellent, information. And we have some questions, but I think I will reserve it till the end of the session.
Okay.
So next moderator is Dr. Ranga Reddy. He will introduce our last speaker for today's webinar. Go ahead, Dr. Reddy.
Thank you, Gautam. First of all, I would like to thank our president, Dr. Sudhakar Janalkada, for asking me to be the moderator tonight's program. And I would like to thank Gautam also for moderating the first 2 speakers. Dr. Gopal and Dr. Kumar, thank you very much for that excellent presentation. And it's my privilege to introduce to you the next speaker, Neil Miraski. Dr. Miraski, am I pronouncing right?
You're doing a wonderful job. Can you hear me?
Oh, yes, thank you. Thank you. Dr. Miraski, he graduated from Nova Southeastern University College of Osteopathic Medicine in Florida. Then he finished his residency in family medicine and a fellowship in hospice and palliative care. Then he became the medical director of so many programs that takes care of the palliative medicine. Now he's the president of Palliative Care Associates, and he lives in Fort Lauderdale, Florida, with his lovely wife, Allison, and their two Pekingese, Winston and Henry. I don't know how many of you are aware of this Pekingese. It is spelled as Pekingese. I had to Google myself to know what Pekingese are. Maybe Dr. Draski will explain it to you. It's my privilege and pleasure again to invite Dr. Neil Miraski to present his topic. Thank you.
Thank you very much for having me, and I appreciate the opportunity. I work a lot with Dr. Kumar, trying to help out in the ICU. And you did hit on the most important point, besides my wife, of course, because she may walk by and hear me, and that is the Pekingese. So palliative medicine, just because there's a lot of preconceived notion about palliative medicine being hospice, this is not a hospice talk. These patients aren't going to hospice. Hospice has nothing to do with this. This has to do with active, comprehensive symptom management to facilitate attempt at cure for these patients. So can I have the next slide, please? So basically, we're going to touch on a couple of things. I'm going to try to keep it brief so that if there's questions in the question and answer period, we'll go there. So we wanted to identify some common symptoms experienced by hospitalized COVID-19 patients, categorize targeted receptors for symptom management and medication selection. The pharmacology of symptom management is basically the focus of this talk because it is how we pick our meds. And then what is a stepwise approach or one stepwise approach and lessons we've learned so far by treating these patients at Broward Health Medical Center. So the common symptoms that we're really looking at, and Dr. Kumar touched on them, is the pre-intubated patient has frequently has signs of anxiety, agitation, and dyspnea. And those signs occur more intensely if they are declining and look like they're going to need additional oxygen support from just nasal cannula or ventimask. These patients also have these symptoms on the back end, post extubation, I should say extubation, never mind. So that post extubation process needs to be managed well so that we minimize the potential for need for reintubation. If we don't manage post extubation symptoms, their risk for reintubation becomes significantly higher. And then we're going to talk briefly about the peri and post intubation period while they're on intubation because these patients aren't normal. They're normal people who are having very abnormal presentations. So when you can have a patient who you would normally be able to sedate, they're opioid naive, they're benzodiazepine naive, they don't drink alcohol, and you can't keep them sedated with a RASS score of -3, even if you give them 50 of propofol with 200 of fentanyl. These people have a massive sympathetic surge associated with the inflammatory response. Next slide, please. So I was going to take each symptom, then talk about the receptor, because that's how you're going to pick your meds. The reason I'm listing it this way is because we are lucky enough to have national shortages of medications and it rotates. So one day we can get diazepam or lorazepam, and one day no hospital can order it. This is a global problem. While I've been at Broward Health treating COVID patients, we've had national shortages of lorazepam. It's gone on back order. National shortages of midazolam, which has gone on back order. And diazepam, as you well know, is impossible to get in IV form these days. So that's why I've listed multiple options. And I'll touch on briefly why you pick each one. So when you have anxiety, you have 3 ways to address it. Go after GABA receptors, go after alpha, or go after SSRIs or SNRIs. When you're going after GABA, these are benzodiazepines. When you're going after alpha, this is Precedex or clonidine. And you can, if you're maximizing one receptor and you're not getting the response you need, go to the next receptor. When you're adding an SSRI or an SNRI, that's not for today. That's for a patient so that you'll be able to manage anxiety post-extubation. So if somebody's really quite sick and looks like they're going to get intubated and they were an anxious person to start with, plan early, get the SSRI in and going. Next slide, please. So agitation is not anxiety. Agitation and delirium are a dopamine problem. If you try to treat agitation with a benzodiazepine, you will be unsuccessful somewhere between 90 and 100%. And the reason it's not 100% is we probably misdiagnosed anxiety as agitation in at 10%. So when you're tracing down agitation and delirium, which is incredibly common in these patients, you need an antipsychotic. So Geodon comes in a PO or an IV form. Risperidone comes in a tablet and an oral disintegrating tablet if you can get it. Seroquel comes in tablet, no IV. Haldol is IV, and Thorazine is IM, and you can drip it IV. You can also do tablets, but there's issues with that. We have found that these patients frequently will present as if they have traumatic head injury when we're trying to extubate them. A lot of impulsivity, and it's going to be something we will figure out looking back. It's not something we understand at this point. We've had a couple of patients that have had significant agitation that is not improved with exceptionally high doses of dopamine concomitantly administered with benzodiazepines. And so what we have found, and we're putting together a couple of articles with this, is valproic acid and then if needed lithium has been effective in all of these patients thus far. Having said that, it's a very small group. Next slide, please. So tachypnia. Why is this a major issue? Well, it has to do with synchrony on the vent. We find for these patients that, I mean, pre-intubation and post-intubation, if you're breathing 40 times a minute, you're not going to get good oxygenation. If we can drop you down to 30 times a minute, your chances of having decent oxygenation improve. Additionally, with the, if you have a patient that's on the ventilator and dysynchronous, there may be benefit in adding an opioid, which is going up to your mu receptor, with the intention of producing respiratory depression, not so that you get respiratory depression below the normal range, but so that you get respiratory depression from an unsustainable respiratory rate with asynchrony to a sustainable respiratory rate with synchrony on the ventilator. So they're breathing 30 times or 36 times on the ventilator instead of 50, or they're breathing 26 times. Next is tachypnia in the conscious patient. GABA has a role to play. In the unconscious patient, it has a role to play, but we'll get into that on the next slide. Can I have the next slide, please? So sedation. This is essentially where palliative intervention, where good medication management makes the biggest difference. This and then also post-extubation to prevent reintubation or to facilitate, along with the intensivist, the elimination of reintubation. So we typically intubate and sedate and, well, let's talk about induction first. So induction, normally for induction, we use some propofol, maybe a little bit of Versed, and a paralytic sometimes. We're finding that in a fair number of these patients, that's not enough. They actually are not stable. They are not synchronous with the vent. And so your propofol can be maxed out at 50, and your Versed can be running at 7 milligrams an hour. And in these situations, even with paralytics on board, a Nembutal or whatever, we need to add ketamine. So ketamine is an NMDA antagonist. So your stepwise approach, we'll get into that. It's an NMDA antagonist. Golden rule with ketamine is you cannot run ketamine without continuous benzodiazepine infusion. You will end up with a person who is not functional if you give them ketamine without a benzodiazepine and you let that run for a day or two, because internally, there's lots of data that shows dissociation, hallucinations, and you could end up with a psychotic patient. So the way you prevent that is you always run a benzo with ketamine. So intubation, you start with propofol, add a benzo. I can tell you that we've lifted the safety protocols on our benzodiazepine doses. So Versed now goes up to 10 milligrams, and we use 10 milligrams, not all the time, but we do find a difference that a patient can be asynchronous with 7, but not with 10. You can use Ativan, but be cautious. Infusions of Ativan over extended periods of time are toxic, and it's contraindicated in renal failure. There are patients that do not respond. They have substance abuse histories, and in those situations, you may have to add, and we have on rare occasion, but it's important, barbiturates. And if you're adding a barbiturate, you can use Nembutal or you can use phenobarbital. Phenobarbital is a lot cheaper. Nembutal is IV. Phenobarbital, you can do IV, but the conversion gets complicated. There are plenty of resources for that. Finally, some patients, we are using antipsychotics as well to assist with sedation. And we're using it primarily for the histamine effect. That histamine effect is not going to cause the patient, it doesn't cause them to dry up, because there's a problem with plugging if you do that. And so you don't want to go down the road of your typical antihistamines. You actually use central histamine effect with antipsychotics. Next slide, please. So stepwise approach. Well, how have we been approaching it and found good responses? So for anxiety, for episodic panic, these patients have underlying anxiety disorders, or they have panic episodes because they can't breathe, or they feel profoundly unwell. The benzodiazepine that's preferred in this situation is clonazepam. It has alpha activity, it has GABA activity, and it has a longer duration of action. It can be given orally. It has an oral disintegrating tablet in patients that have, even if you're on BiPAP, you can slip this on the tongue, even if they're NPO, and they'll get the medication. If you're doing it by feeding tube or PEG, under new NIOSH guidelines, this has to be prepared under hood. So just write the order for suspension, and pharmacy can prep it. If the anxiety is present without panic, diazepam or lorazepam are good choices, except avoid lorazepam in your geriatric populations and your renal failure populations. The American Geriatric Society and the Academy of Hospice and Palliative Medicine both have positions about lorazepam in the geriatric population. Next slide, please. So for agitation, remember, agitation is a dopamine problem. If they have a hypoactive delirium, these people are withdrawn. They're not they're not restless and acting out. They actually can't follow you, can't interact. They appear encephalopathic. Risperidone is well tolerated. It's good in the geriatric population. And then haloperidol is old, it's clean, it has multiple formulations for delivery. It has an exceptionally wide dosing interval. So haloperidol is a perfectly acceptable course, especially in a person with no oral route. Hyperactive delirium, Geodon and Seroquel, or Seroquel and Geodon can be used. If those agents are not effective, we'll talk about Seroquel briefly, then we've been using Thorazine. I, because of my training, have a lot of experience with Thorazine. It's not a common medication used, but I can tell you the psychiatrists are starting to use more Thorazine, and we're a Baker Act receiving facility after interaction with Thorazine in our ICU patients. It has a high potency on the histamine effect, so it's incredibly sedating, and you can drip it. If you're going to drip it, you have to mix it in normal saline, and it's 25 milligrams infused every half hour. The dose range I'm using is between 25 and 100 milligrams IV every 8 hours, infused at 25 milligrams an hour. Seroquel or quetiapine is an agent that has a stepped benefit at less than 100 milligrams Q8 or Q12 or even daily. You're getting no dopamine effect and mostly histamine effect. If a person is delirious or agitated, this won't work to help their delirium until you get above 150 milligrams every 8 to 12 hours. And then mood stabilization and impulsiveness, we're seeing this post-extubation, and we're using first valproic acid if needed. This is definitely not something that's common, but I can tell you I've used it in probably 5 to 6 patients, and it's been a lifesaver. So don't start a benzodiazepine without an antipsychotic. You can add a benzo for an agitated delirium or a hyperactive delirium. That's absolutely fine, but don't leave the antipsychotic out, or you'll have a person who wakes up just as disorganized as they were when they went to sleep. And of course, monitor QTC intervals on these patients. All of these have black box warnings about QTC prolongation. Next slide. So stepwise approach to sedation. When they come in, you can use propofol, whichever opioid you like, midazolam, or Ativan if you prefer. Then if that's not working, your next step is ketamine. You can actually flip ketamine and paralytic back and forth. It depends. Prolonged paralytic use is not a good idea, and prolonged ketamine is not a good idea. So once you get initiation in place, you should try and pull down your paralytic and pull down your ketamine if needed. Next slide. For maintenance, it's propofol, fentanyl, midazolam, ketamine, and there you see thorazine. You could use Geodon. You can use any of the agents that you would like to, but get something that's sedating. Next slide. So lessons we've learned. Can you go back one slide? Thank you. So one thing, when we're weaning patients to come off, we would change propofol over to Precedex. I would probably keep midazolam as a choice because of its shorter duration of action compared to Ativan when you're trying to wean down and get a patient off intubation and ventilator support. Fentanyl, all of the opioids are decent choices. So pick any of those. And ketamine, you can't take off, you see the order, you can't take off the ketamine. You can't take off the benzo before you take off the ketamine. Ketamine must come off first. Next slide, please. So lessons learned. Agitation is very common when patients are being intubated, extubated, and post-extubation. Have a very low threshold to start antipsychotics. And if you have a patient that has been intubated for a long time or was particularly agitated when you needed to intubate them, they have no history, no psychiatric history, that is still the indication to start an antipsychotic. You can always pull it off, but as far as neuroleptic malignant syndrome, tardive dyskinesias, and other things, we haven't seen any of it. It's of course a possibility. We always need to watch for it, but low-dose antipsychotics have been very helpful in managing agitation and getting patients not to go back on the vent because they have uncontrolled tachypnea from anxiety and confusion. Next, these patients are atypical and usually require significantly higher doses than what you're used to. Our Precedex has gone up to as much as 1.4. Our fentanyl goes to 200 or 300. Quite frankly, if fentanyl 200 isn't working, pick morphine or Dilaudid. And Versed and Ativan have both gone up to 10 milligrams. That's where pharmacy has set our new stops in COVID patients. Use of opioids for tachypnea is beneficial. I mean, one thing is, of course, you need to provide them oxygenation, but if despite all the support, they're still at tachypnea because of their underlying disease, bring them down to a respiratory rate of 30, use an opioid to suppress respiration to 30 while they're monitored. Medication shortages are common and varied. That's why I've given you the receptor approach, because that way, when you lose one drug, you can pick another. Tachyphylaxis in midazolam is seen at about 2 weeks. You have these patients intubated and they're on a Versed drip, and all of a sudden they start to get more unstable, more restless. Their RAS score seems to be going up for no reason. Rotate their benzo. We found that the GI route in these patients is reliable and functioning. You can give scheduled oral scheduled diazepam, olorazepam. We've done both. When we first started this, we were told we were going to have shortages of meds, and everybody got it. Be careful. These meds stick around a long time. So when you're getting close to extubating a patient, get them off the oral route. But if you're having that big shortages, supplemental your IV benzos with orals, it works. Avoid protracted infusion of lorazepam because of renal failure, and stay away from Zyprexa. It's a wonderful medication, but we have black box warnings and unexplained death without a known mechanism with benzodiazepines. So while we use this a lot in other patients, and fortunately Florida had the FLACA experience, and Zyprexa was the agent of choice with Ativan. These people have enough challenges and this change has happened. So for now, we have other options. Just stay away from it until we know more. I believe that's my last slide. Yep, thank you very much. And now we can go to the moderator.
Yeah. Thank you, Dr. Mirasky, for a very good presentation, which happens to be my specialty, being an anesthesiologist. It looks like a refresher course for me. Thank you. And we have about 10 minutes before we finish this session. I would like to request my friend, Dr. Gautam Samadar, to deal with some of the questions for the first two speakers. And then if there is a time, we can also deal with any questions to Dr. Mirasky. Gautam.
Thank you, Dr. Reddy. Excellent presentation with all three speakers. And this topic was very dear to me because I have a personal experience with my wife. She suffered from COVID, was almost 3 months in the hospital, recently discharged with all possible complications related to COVID. So I have personal experience, and I think all the speakers touched on all the important points. So the questions will be divided among the speakers. First with Dr. Gopal. The questions which were asked, I won't ask you, tell you the names, but in common, use of dexamethasone very early in asymptomatic patient who are without hypoxia or respiratory failure. This was a question asked to you, Dr. Gopal.
That's an excellent question. The dexamethasone, the recovery trial, I'll answer that question. The recovery trial, what they showed was the DEXA was beneficial in people who got oxygen support and on mechanical ventilation. So that trial said that people who didn't need oxygen, actually, they had more harm with DEXA. That's what that trial showed. But when I see a patient, I look at if they are in the hospital, they are there for this reason. So I look at the symptoms, I look at the lab values, and then I look at the risk factors too. Not just the hypoxia. Sometimes, I've seen like a case where the inflammatory markers were very high. There was a patient with ferritin 2000, and then she had some risk factors too, diabetic and an African-American female. And she was not hypoxic the first day I saw her. But I started her on, dexamethasone. But then the next day, she had hypoxia and things like that. So it is a case-by-case decision in terms of the DEXA and the risk versus benefit. And if I'm seeing a patient in the first week and they have no hypoxia, the chest X-ray is fine, the CT has no ground and everything, and just a little fever, and no risk factors, I may not give DEXA. Versus if a patient is coming in towards the second week, that's where after the second week we see some, complications, and they've been at home quarantined for a week, and then there is no improvement. And then I look at the risk, and if there is risk, my threshold for giving the DEXA, low dose DEXA, is actually, very low. I may just give them the steroid. We need more information just based on the trial and just on the oxygenation level. That's not the decision for DEXA that I make.
So, Dr. Gopal, one personal question. You know, with all the COVID experience, that patients are symptomatic, and then suddenly, for 1 or 2 days, they are asymptomatic, and then the cytokine storm comes. And so, with that in the background, do you think if a patient is symptomatic early, giving DEXA will prevent the cytokine storm to happen? What is your experience?
Yeah, that's why I said my threshold for dexamethasone is actually low. You know, if and then the DEXA, it doesn't have to be 10 days. They are mildly symptomatic. I've given lower dose of dexamethasone, shorter course, and they have improved. So my threshold is actually low. And then one of the aspect, there's problems with steroids is high blood sugar and things like that. But some of the people, it doesn't cause too much harm. And I've never seen anybody having any issues with steroids. So definitely, yeah.
Thank you, Dr. Gopal. Dr. Kumar, I have few questions to you. Hopefully we can cover that. One question I would like to cover on ECMO. Is it true, all the ECMO centers have some algorithm, but is it true that ECMO is most valuable on the 7th or the 8th day of ventilator to prevent further lung injury and prevent pulmonary fibrosis? If it is past that period, then ECMO has very little role. Any comment, Dr. Kumar?
Yeah, so this is based on those couple of studies that I was mentioning when I was talking about ECMO. So University of Texas, what their protocol was, they obviously looked at the Murray score and they looked at the REST score. And if the mortality is still, or the benefit is still about 40%, and the patient has been intubated less than 7 days, that's when they used ECMO and they saw a benefit. That doesn't mean there is no other benefit. I mean, it all varies from patient to patient, right? I mean, if I see a 30-year-old with a single organ failure, clearly I'm going to try whatever I can to save that patient. At the same time, on the other spectrum, you know, somebody is, I mean, no offense to anybody, if somebody is 70 years old and has been on the ventilator for 2 weeks and you do the RESP score and your, you know, scoring is like -2 or -3 and the mortality is 80% and the lung is already fibrotic, your benefit obviously is very, very little. So that's not a patient that I would consider. So it varies from patient to patient.
Next question for you, Dr. Kumar, is anticoagulation. We all know COVID has this phenomena of microemboli to extremities, people having strokes and everything. So even if the D-dimer values are low, role of starting the patient as soon as they end up in ICU, a role of anticoagulation from day one, what's your thought?
So again, we don't have any kind of randomized controlled studies to prove anticoagulation at what level is going to help, right? I mean, we're all going with arbitrary numbers. So looking at D-dimer to use anticoagulation is not something that is very well documented. Using TEG for anticoagulation is not very well documented. So none of these things are documented in COVID patients. So I think I mentioned, if a patient is admitted in the hospital, they are on prophylactic Lovenox. Doesn't matter as long as their D-dimer is 3 times up, less than 3 times upper limit of normal. If they are between 3 to 6 times, we use half the dose of Lovenox. And if it is over 6, we use full dose Lovenox. Now, again, this is not proven yet. Have we seen benefits? Absolutely. The first, I think probably about 10 days, we didn't use any anticoagulation, but after 10 days, we started using anticoagulation and proning combined, and we started seeing mortality benefit. There is no question about it.
Gautam, this is Rangareddy. We have time for one more question, please.
For Dr. Kumar? Or anybody?
No, for anybody. Only one more question before we close.
Reddy, I will give this opportunity to your last speaker, if you have a question for him.
Yeah. Is there any question for Dr. Miraski? Dr. Miraski, can you tell what are the picnics?
What are the Pekingese? The Pekingese.
Yeah.
What a wonderful use of people's time. They're wonderful little dogs that can be very, very moody. So unless you're an experienced dog owner, don't go there. Get a poodle.
Okay. Okay. Thank you. Thank you. Back to our
Pleasure.
President, Dr. Sudhakar Jonalagada.
And
Sudhakar, are you there?
Yeah.
Sure. Yes, sure.
Dr. Gopal? Go ahead.
I see one question. I think there is a question. Is there any trial favipiravir in USA? But there is, yeah, I know there is a trial in Brigham and Women. They are doing a trial on favipiravir. Okay.
I think there is one question, probably, Dr. Kumar. Are you giving anything else other than anticoagulation to prevent pulmonary fibrosis in patients who recover from respiratory failure?
Anything other than anticoagulation to prevent pulmonary fibrosis?
Yeah.
I mean, I don't think there are any proven medications to prevent pulmonary fibrosis in ARDS, right? I mean, as we all know, once ARDS sets in, it is all supportive care. And especially in COVID, I think once the fibrosis is there, and it's pretty much none of these treatments work, in my opinion. The cytokine storm is already done. It's an after effect of it. And even Actemra probably has a stage in the early phase of intubation. The patient is intubated within 2 to 3 days. That's when we use Actemra.
Sunil, one more.
Yeah, go ahead.
Last question, Sunil, to you. Is it true that pulmonary fibrosis, pure COVID patients, the fluid they have is not very infectious, but if they have superimposed bacterial pneumonia, they are the ones who are going into pulmonary fibrosis? Any thoughts?
Not that I have seen in any of the studies. And I think, well, first of all, we were not routinely culturing these patients in the beginning, right? For obvious reasons. We don't want to expose anybody to get any of those deeper secretions on these patients. And we haven't really seen that kind of super infection till we started using Actemra. Otherwise, the patient is intubated for 2-3 weeks and tracheostomy and all. That's when we started seeing super infections. So I haven't really came across any studies to show that it's a bacterial infection that is causing this. I think it should be the other way around if you theoretically look at it.
So what is the pathophysiology? It is the high pressure toxicity of the lung which is causing pulmonary fibrosis, or there is another infectious cause?
I don't think it's an infectious cause. Again, don't quote me on this. I can't prove it. I think this is an inflammatory disease. I think it's an inflammatory disease, and I think it is a vascular disease. I think we are focusing on the wrong organs and the wrong pathology. I still think we have to go back to the initial thoughts of why this why this thrombosis happens. I mean, why do 35-year-olds come in with a stroke? I mean, we had multiple patients just coming in, no past medical history, no obesity, no risk factors, just acute stroke. And when we go in to do thrombectomy on these patients, their blood vessels are severely damaged. And we even had a couple of patients where after the thrombectomy, the blood vessels ruptured, and those vessels are really affected.
Okay.
Thank you, Sunil.
Thank you again. Thank you for the speakers for outstanding webinar today. I want to thank you, Dr. Miransky, Dr. Gopal, and Dr. Sunil Kumar for joining us today. And you guys did a great job. And of course, our moderators, Dr. Samadar and Dr. Rangareddy, for outstanding moderation. Thank you very much. And you all have a great evening. Good night.
Good night.
Thank you all.
Thank you.
Good night.
Thank you all. Good night.
Thank you.